Good afternoon, good morning, everyone. Bonjour à toutes et à tous. Today, I'm very pleased to share with you my annual report on the state of public health in Canada. It was tabled this morning in Parliament by Minister Hajdu and is called From Risk to Resilience, an Equity Approach to COVID-19. I deliver an annual report on the state of public health in Canada every fall as a requirement of my role. At every press conference, I report on the latest COVID-19 cases so Canadians can better understand the scale and trajectory of the pandemic in our country. While statistics are important, we must not forget that behind each number is a person. That person may be an elder and have health conditions and living in a long-term care home, or is someone struggling to make ends meet, or is someone living with homelessness. Others have lost their jobs or are on the front lines, putting them at direct risk of infection. These are people that have been disproportionately impacted by this pandemic, and through my annual report, I'm shedding a light on the inequities too many people have and continue to face. The impacts of COVID-19 in this country have been worsened by systems that stigmatize populations through racism, ageism, sexism, and others who have been marginalized through structural or social factors such as homelessness. Reports from around the world show there is a real difference in who gets COVID-19 and how severe their illness is. These differences are not random, but fall along the lines of populations that have historically experienced health and social inequities. The fact is that the impact of COVID-19 is influenced by factors such as income, the type of work we do, how many people we live with, and if we depend on someone else for our day-to-day living. The impacts have been worse for some groups, such as seniors, workers who provide essential services, such as those in healthcare or agriculture, racialized populations, people living with disabilities, and women. The virus didn't create new inequities in our society, it exposed them and underscored the impact of our social policies on our health status. Another major consequence of the pandemic is the opioid crisis, with overdoses and deaths again on the rise. There are indications that the street drug supply of opioids has grown more unpredictable and toxic due to the pre-pandemic supply chains being disrupted by travel restrictions and border measures. These findings are more than just uncomfortable facts about our country during this pandemic. They are the lived realities of countless Canadians. In conclusion, I want to say that we have seen tremendous commitment and leadership across Canadian society, from governments, businesses, and civil society. Going forward, we need to focus on three key areas. We need to sustain the collaborative leadership that has been tremendous during the response to ensure that health, social, and economic sectors work together to protect Canadians from pandemics and reduce inequities. We need to continue to build social cohesion. Public health leaders, policymakers, and media need to demonstrate that we're all willing to work together to share information, stories of success, and collaboration towards the goal of getting through this crisis. Only then will Canadians be able to trust credible information and make the daily choices necessary to prevent transmission and protect those at higher risk. Lastly, we need to strengthen the capacity of the public health system so that it can surge during emergencies, partner with other sectors, and leverage the science from academics and universities while maintaining critical work like reducing opioid-related deaths. By working together to address the inequities that underpin our society, we'll move from risk to resilience and build a better, healthier society for all Canadians, now and beyond COVID-19. My bottom line is, no one is protected until everyone is protected. Thank you.
Bonjour à tous et à toutes. Aujourd'hui, la Dr. Tam a le plaisir de vous faire part de son rapport annuel sur l'état de la santé publique au Canada. Le rapport a été déposé ce matin au Parlement par la ministre Hajdu et s'intitule « Du risque à la résilience, une approche axée sur l'équité concernant la COVID-19 ». Chaque automne, elle présente un rapport annuel sur l'état de la santé publique au Canada dans le cadre de ses fonctions était l'administratif en chef de la santé publique. Lors de chaque conférence de presse, nous faisons rapport sur les derniers cas de COVID-19 pour que les Canadiens puissent mieux comprendre l'ampleur et la trajectoire de la pandémie dans notre pays. Bien que les statistiques soient importantes, il ne faut pas oublier que derrière chaque chiffre, il y a une personne. Il peut s'agir d'une personne âgée qui a des problèmes de santé et qui vit dans un centre de soins de longue durée, d'une personne qui a du mal à joindre les deux bouts ou d'une personne vivant dans l'itinérance. D'autres ont perdu leur emploi ou sont en première ligne, ce qui les expose directement à une infection. Ce sont des personnes qui ont été touchées de façon disproportionnée par cette pandémie. Dans son rapport annuel, il souligne les inégalités dont ont souffert trop de gens, dont ils souffrent toujours. Les répercussions de la COVID-19 au Canada ont été aggravées par des systèmes qui stigmatisent les populations par le racisme, l'agisme, le sexisme et d'autres facteurs structurels ou sociaux comme l'itinérance. Des rapports provenant de partout dans le monde montrent que la COVID-19 frappe plus durement certains groupes que d'autres. Le fait est que l'incidence de la COVID-19 est influencée par des facteurs comme le revenu, le type avec la pandémie, elles ont été exposées. Et la pandémie a fait en sorte de souligner les répercussions de nos politiques sociales sur notre état de santé. Une autre conséquence majeure de la pandémie est la crise des opioïdes, les surdoses et les décès étant de nouveau à la hausse. Il y a des indications selon lesquelles l'approvisionnement en opioïdes dans les rues est devenu de plus en plus imprévisible et toxique en raison de la perturbation des chaînes d'approvisionnement pré-pandémiques par les restrictions aux déplacements et les mesures frontalières. Ces constatations ne sont pas seulement des faits troublants au sujet de notre pays pendant cette pandémie, et sont la réalité d'innombrables Canadiens. En conclusion, nous tenons à dire que nous avons été témoins d'un engagement et d'un leadership extraordinaire dans l'ensemble de la société canadienne, de la part des gouvernements, des entreprises et de la société civile. À l'avenir, nous devons nous concentrer sur 3 domaines clés. Numéro 1, nous devons maintenir le leadership axé sur la collaboration qui a été extraordinaire pendant l'intervention afin de veiller à ce que les secteurs de la santé, des services sociaux et de l'économie travaillent ensemble pour protéger les Canadiens contre les pandémies et réduire les inégalités. Numéro 2, nous devons continuer à renforcer la cohésion sociale. Les dirigeants de la santé publique, les décideurs et les médias doivent démontrer que nous sommes tous prêts à travailler ensemble pour échanger de l'information crédible, des histoires de réussite et une collaboration en but de surmonter cette crise. Ce n'est qu'à ce moment-là que les Canadiens pourront faire confiance à l'information et faire les choix quotidiens nécessaires pour prévenir la transmission et protéger les personnes à haut risque. Et finalement, nous devons renforcer la capacité du système de santé publique afin qu'il puisse répondre à la demande en cas d'urgence, établir des partenariats avec d'autres secteurs et tirer parti des connaissances scientifiques des universités, tout en maintenant le travail essentiel comme la réduction des décès par surdose d'opioïdes. En travaillant ensemble pour éliminer les inégalités qui nuisent à notre société, nous passerons du risque à la résilience et nous bâtirons une société meilleure et plus saine pour tous les Canadiens, maintenant et au-delà de la pandémie de COVID-19. L'essence du message est ceci. Personne n'est protégé tant que tout le monde n'est pas protégé. Merci.
Thank you. We will now take your questions, starting in the room. Vous pouvez poser vos questions dans l'une des 2 langues officielles. We ask that you limit yourself to 1 question and 1 follow-up. For those asking questions in the room, please make your way to the freestanding mics. We'll start with CTV.
Dr. Tam, Kevin Gallagher, CTV National News. In your annual report, it made clear that 80% of the fatalities from COVID-19 were residents in long-term care facilities. As we are in the second wave now, have there been significant changes to avoid this type of deadly outcome, or is Canada doomed to repeat the mistakes of the spring?
Well, we've learned a lot more about this virus and the populations at risk. So, everything has been done to prevent the repeat of what we're seeing in the first wave. So I do know that a number of specific things have been provided to support long-term care facilities. Some of them at the federal level in terms of support, well, we provide guidance, but there's a number of inquiries and commissions that have come up with recommendations as well. I think what we have seen is that there's been a number of best practices, for example, just infection prevention control practices within long-term care facilities, and they have to be followed really diligently. And so that's really, really important. The screening every day of anyone who enters facilities, rapidly testing people who are ill, and doing widespread testing if there's an outbreak, the isolation, supporting people in that isolation and quarantine is really important in those settings. At the same time, I think some of the best practices, I have seen this being implemented in certain provinces very well, is to ensure support for the workers. So I just talked about workers, many of them are personal support workers, who are, many are from sort of racialized communities, not being paid well, do not have sick leave benefits. Is some of the federal supports is to help with that, so that people can stay home with their sick. And also that support workers so that their wage is equalized, if you like, between the public and private sectors. That has worked in then keeping workers as much as possible to a single institution. So that's really important to do. And so that you don't necessarily transmit between different facilities. And so I think it should be a very, very comprehensive approach. We've also provided surge capacities, whether it be testing, contact tracing, but also the Canadian Red Cross, providing some of the supports where human resource capacity is an issue. So I do, I am wanting to be optimistic that we can not repeat what we're seeing in the first wave. However, if you look at the statistics right now in the second resurgence, we are seeing that while cases are mostly still the highest rates in the younger adults, it's beginning to penetrate into the older age groups. We have had quite a number of reports of cases in long-term care facilities. One encouraging sign is that for the most part, those have been smaller outbreaks. So it tells me that people might be detecting them faster and then containing them. But there are a number of long-term care facilities where they've had more than one outbreak now. And those are the sort of targeted approach. We need to spot who they are and sort of go in and say, what more help do you need? Because clearly there are still missing factors that are not being addressed. So I do think that we have every opportunity to prevent what we saw in the first wave, but that we need to really target areas that are still not quite there yet.
You mentioned in the report, of course, addressing the systemic inequalities that in many ways are the root causes of some of these less than ideal healthcare outcomes. And it does seem like it's more than just the COVID-19 pandemic when you're talking about. Have you seen any evidence that levels of government are truly addressing these systemic root causes to the inequalities that are currently plaguing the healthcare outcomes that you want to see for Canadians?
Yes, and I think, as I said, COVID-19 has shone a real spotlight on the inequalities in health and in systemic gaps resulting in inequities. I do see COVID-19 as a catalyst for collaboration between health, social, and economic sectors. And I have observed that at the federal level, but also from local level and provincial levels. So as an example, of course, at the federal level, which is where I do a lot of the work, is that different departments have, as I said, put together some of those policies that are so vital. I believe yesterday there was more announcements on supporting housing. Housing, in public health terms, is an absolutely really important determinant of health. If you put a roof over someone's heads, they're likely to thrive much better and address some of the underlying health conditions compared to those who do not have a roof over their heads. I have seen, of course, as I've just said, some of the supports for low-income earners who have precarious work. So those who are in precarious work conditions will do less well under any health crisis. So I have seen some of that as well. Support for violence against women, support for shelters, support for food security, support for childcare and education. So these are really important developments, as well as governance tables that engender this intersectoral collaboration. What I'm really, really keen to see is that this continues, because a crisis helps us sort of understand and make it really real what's happening. We understand that as the individuals, often racialized, as I said, often women working in precarious work conditions, who may be single parents, are trying to essentially look after our elderly and our most vulnerable populations. So the question really in this report is calling for this to be a more sustained approach. So why can't we have those governance structures beyond the crisis and into recovery? And why can't we have these intersectoral collaborations, which much of it happens at the local level, continue, and that different governments support that kind of collaboration? So that's what I would champion and will continue to support. I'd like to just, there's a quote that I really love from Dr. Naomi Lightman, who's a social scientist, who said that the most vulnerable workers provide the most essential services to the most vulnerable clients under the worst working conditions. So that's the kind of situation that now every Canadian is now aware of. Before, it may be invisible. Now it's blatantly obvious. And that I trust that everybody wants to reverse those kind of trends. And one of the key aspects of collaboration is actually on data. So I pointed out the fact that you need to have health, social, and economic data come together so that we can shine a light on what is working, what is not working, which area of Toronto has most impacted, so that we can direct resources and affect action. And so I was very pleased to see the Statistics Canada did publish some of the key data now showing the differential, disproportionate impact on areas of the country, neighborhoods with a higher proportion of visible minorities who are doing those kind of essential work. So I would say that we just got to keep at it. And one other thing that I pointed out is that when we do pandemic planning going forwards, it can't just be health and public health trying to make it known that all other departments and different sectors and different aspects of societies need to be part of the response. We need to sort of build it in explicitly so that future pandemics and health crises have those other supports come into play immediately. maybe I'll stop there.
Thank you, Doctor. Next question, CP.
Good morning. This is Mal Hamidi from the Canadian Press. I want to ask you about COVID cases and deaths in Quebec. Now, we have different numbers from in different provinces, but numbers in Quebec seems to be always higher than other provinces. Why is that? Why do we have higher COVID cases and deaths in Quebec than other provinces? Is there anything special about Quebec?
I mean, certainly the province of Quebec and its local municipalities, I think, will have a much more in-depth understanding of their different situations. But I do know that Quebec, of course, is one of the biggest provinces. It was one of the most impacted during the first wave. It had one of the highest impacts in terms of long-term care as well. But I do think that, like the rest of the country, I think one aspect of my report is talking about social cohesion. We need to make sure the population is continuing to observe public health measures. That's really important. One thing that I think, and again, it's more within the local jurisdiction to look at, is that I think, as Dr. New may have pointed out yesterday, that once community transmission gets to a certain point, is that we need to be really careful about your public health system being able to keep up. So there may be specific aspects of that. So getting your lab testing done, getting your contact tracing, as well as isolation and quarantine are fundamental. So that may be playing into that as well. And there are some long-term care facility outbreaks and seniors now being impacted. So that needs to be watched really carefully. But I suggest it's probably multifactorial. The Statistics Canada report that just came out is probably just verifying facts that Quebec already knows, is that the rates are higher in the neighborhoods with the highest proportion of visible minorities. Montreal has neighborhoods, particularly in Black communities. So under those circumstances, doubling efforts to focus on providing support, whether it's lab testing or anything else, in those communities, I think would be extremely important.
Thank you, follow-up.
Another question. Now, yesterday, Canada has reached the milestone of 10,000 deaths. Now, I want to ask you how Canada is counting deaths, because as you know, there are a lot of misinformation online about claiming that there is overcounting of COVID deaths. So can you just explain to Canadians how Canada is counting COVID deaths?
Yes. So at the moment, the deaths that are reported, again, they are individuals. We mustn't forget that behind every statistic is a person, and those persons are very much likely to be seniors. Who many of them may be coming from long-term care, but other areas as well. So these are overall lab-confirmed persons who have died with a lab diagnosis, basically. They may have underlying medical conditions. So sometimes it's difficult to say what triggered the final death of that particular individual, but they're individuals with a lab diagnosis. So that's what's been counted. The Statistics Canada, again, put out a report today on what we call excess mortality. So they look at, what is the general trend over a number of years, and then what's above that trend this year. And I think it shows that the majority of the excess mortality can be accounted for by COVID-19. But there could be other excess mortality, sometimes as a result of some of the measures that we've put in, and the opioid crisis I've highlighted as well. So I think we need to look at the severe impacts in a more holistic way, not just COVID-19, but other deaths as well. But that's basically what's being reported.
Thank you, Doctor. We will now turn over to the phone. Operator.
Thank you. Merci. Please press *1 at this time if you have a question. S'il vous plaît, appuyez sur étoile 1 maintenant pour poser une question. And our first question is from Tonda McCharles from Toronto Star. Please go ahead.
Hi, Dr. Tam. One of your other recommendations in that report or findings is that public health capacity has to increase. And so I'd like to hear you speak about exactly where you see the biggest need right now. Is it at a federal or provincial level? What exactly would you like to see? You mentioned data collection, but what other specifics can you point to, and at what level do those need to be reinforced?
Yeah, I would say probably at every level. And there are different public health functions that happens at different levels. I think what this pandemic, again, has shone a spotlight on is the importance of public health and its role in prevention, in health promotion, in making our communities more resilient, as well as, of course, there's capacity that's needed in the healthcare system. But the public health system as a whole represents a very small part of the total health capacity. And so as a result, everyone is working extremely hard, but you can see some of the limits, and that we had to pull in surge capacity from different areas, including the Canadian Red Cross, including students, including retired people, to show up that capacity. So one part moving forwards, particularly in pandemic planning, is to, one, have the necessary systems strengthened, and they may be data systems, IT systems, but also be able to scale it up. So having a flexible platform upon which you can scale up your measures. So I would suggest there's several aspects of public health strengthening. One is the capacity to work across key systems, so that we have the data and the IT platforms that can link health, social, and economic data. We need to have investments in population and public health research, applied public health research, link across to social science, behavioral science, in order to have that kind of rapid data generation that's needed, and which is anchored in health equity. Third area, I would say, is evidence-based science communication as a core function. And that is really critical, and journalists play a role in that, to the capacity to dispel misinformation, to point to credible information in order to build trust and that social and societal cohesion that I spoke about as well. I think great leadership and the public health leaders in our decision makers, so that they're integrating health equity into overall planning and policy. And Dr. New and I was just reflecting on the fact that one of the key tenets of public health, and where our key aim is to have healthy public policy, not public health policies, so that you're integrating healthy policies into all the other policies, if you like. So we need to be able to do that. But we need, I think, ahead of any pandemic emergency, to exercise plans. So the plan should be multi-sectoral. We should be able to rehearse these plans on a very regular basis at different levels, so that we don't forget the lessons that we've just learned through COVID-19. One thing that is difficult, I think, for public health is to advocate for sustained investments and avoid the sort of boom and bust, the sort of panic and everybody recognize we need to invest, followed by more complacency when we've done our job. Public health is invisible when there are no cases, when we've done our job. So it's very difficult to advocate for public health capacity when you've prevented things from happening. But that's what we must do. And so, we need capacity to do the intersectoral connects, to hire people that are from diverse disciplines and backgrounds, to make these integrated approaches a sustained reality.
One of the questions I have around, and maybe this is answered in the StatsCan report you referenced earlier, but I am curious. You mentioned the investment in housing for the homeless yesterday. How many people in this pandemic, how many homeless people have died of COVID, whether or not they were literally on the street, and they may have been in a temporary shelter at the time? How many homeless people have died of COVID, or directly their whatever excess mortality reason you might say was the reason for their death, but it flows from COVID or the pandemic. Have you got any idea of the number or a percentage or the rate at which that population's been hit?
Well, I think there's multiple layers to have a look at how the pandemic has differentially affected those who are experiencing homelessness. We do have a number of reporting of outbreaks, for instance, in congregate living settings that includes homeless shelters. So we keep track of those. I don't have the exact numbers in front of me, but we'll get back to you on that. And then the number of people associated with those outbreaks. But we also look at indirect and indirect impacts, and that includes the other kind of health impacts, whether it's the opioid crisis or other aspects that is impacting people experiencing homelessness, food insecurity. So these are intersectional impacts. But the StatsCan data does point towards, neighborhoods. We have another saying in public health that your postal code really matters. It's as important as your genetic code, where you live, and so, or where you don't have a home. So that's a really critical aspect of the determinants of health. But one thing that I have to say is that given some of the investments, I know that at the municipal level and with federal support, people have been able to book hotels, to increase physical distancing, to have isolation accommodation for persons experiencing homelessness. That's a temporary measure. So what we are suggesting, and with further investment, is rapid housing, like I think some of the announcements. And so I do see COVID-19 as a catalyst for that kind of action, and that I really will continue to champion for sustained action in that area.
Thank you, Doctor. Opérateur, prochaine question.
Yes. The next question is from Tessie Sanchi from Hill Times Research. Please go ahead.
Hi, thank you for taking my question. Dr. Tam, I'd like to go back to the issue of, the social determinants, and you referred to cross-sectoral leadership tables that have been going on, kind of this cross-department working together. My first question is around whether the Public Health Agency has been involved in those leadership tables, and just going forward, sorry, I'm hearing a bit of an echo. Going forward, could you anticipate PHAS having a greater role?
Thank you very much for that question. So I think there's different aspects of this. One is that I'm really pleased through this pandemic that I've been introduced to a whole range of deputy ministers' tables at the federal level. So deputy ministers involved in social policies, well-being, so I would look forward. The Public Health Agency and Health Canada do participate in those tables, but as the Chief Public Health Officer, I was definitely reach over and ensure that I get the opportunity to speak to deputy ministers in a diverse way. I've already done that, actually. The report was tabled today, but I already got my phone calls in to speak to interdepartmental deputies. I think I'm also in a privileged position to be able to speak to the health ministers across provinces and territories and our minister to advocate for interdepartmental, interdisciplinary approaches. And I'm able to reach across the other chief medical officers of health who are doing the same. And many of them have reflected to me that they also have the experience that they've got these intersectoral tables right now, and they want to be able to solidify that going forwards. I've also reached over to interdepartmental tables that are looking at strengthening data collaborations. So as you might imagine, that includes Statistics Canada, the Canadian Institute for Health Information across the health portfolio, Canadian Institute for Health Research. I've already started that too. And the Pan-Canadian Health Data Strategy has begun with some short-term priorities that includes collecting information in an inclusive way, in a culturally safe way on race, ethnicity, indigeneity. So I will also advocate for interdisciplinary collaborations of research funding organizations, and I'm doing that also to make sure that scientific disciplines can work together to inform policy. So there are many things, and yes, the Public Health Agency is at some of those tables, but we need to be like really, really make ourselves visible. Thank you.
Tessie, good follow-up?
Okay, thank you. I'll look at the issue of data. Data is obviously a pre-COVID problem. And I'm just curious, you know, I understand we're in the second wave, we have to go through recovery, et cetera, but could you anticipate kind of doing, I don't know, like a national project on how do we get data more consistent across the country so that you don't have all these different forms of data coming into public health or other federal departments when it's needed? Because that was, I believe that's always been an issue, which is that the information systems across the country are very different one from another.
Yeah, I think you've hit on a sort of really important aspects of strengthening public health going forwards. So we are, as I've just said, working on a pan-Canadian national health data, you know, big piece of work. And the federal government did provide some funding because I think that's important. We can't sort of get data out of a system if there's no resources behind it. So I think that over $4 billion worth of support that includes data, lab testing, and contact tracing, which all has to come together from a data perspective. We've been doing a lot of work, of course, in data standards and norms, and that has to continue. But of course, we have to depend on our federal, provincial, territorial colleagues to agree to those standards. So as the sort of most immediate term, we've agreed on a new core national data set. As I said, that does include some of the key pieces of data that is involves race, ethnicity, but also things like, really important things like occupation. Because we want to understand more about the data pertaining to persons who work in the health services, for example, and that we've just started as well. But what you said is very important, and I can't stress enough the ability to standardize information, and that's just part of the path going forwards. Also have that data entered in the most efficient way so that you know, people along the continuum of the data entry to data analytics isn't having to do that kind of thing multiple times. So I think it is a constant bit of work, I have to say, but you have to do that so that when the next health crisis comes together, we are best supported. I'll just reflect maybe a little bit even on data related to mortality. I think we got a question there. I had to work really hard during the opioid crisis to bring together the coroners and medical examiners of provinces and territories who've never done surveillance, never reported through that system. Their role is to do a really, really thorough job in determining the cause of death under certain circumstances. And they've been brought on board, and they have also helped in this crisis as well. So those sort of investments in systems and networks will pay dividends. But it is still a significant piece of work going forward. I do hope that some of that investment will help, at least, for us to help get that common goal.
Thank you, Operator. Next question.
Thank you. Once again, please press star 1 at this time if you have a question. De nouveau, n'hésitez pas à appuyer sur étoile 1 maintenant pour poser une question. And we do have a question from Grant Robertson from Globe and Mail. Please go ahead.
Hi, Dr. Tam. You mentioned the boom and bust nature of public health in the past and the risk of complacency between crises. I guess I have a two-part question. When you talk about that, is it primarily a funding issue, or is it an issue of maybe the country taking our eye off the ball in between crises? And secondly, for things like funding and pandemic prep that we've heard so much about, has the Public Health Agency had the ear of government enough in the past, and do you think it will now going forward?
Yes, in relation to the first question, I do think obviously people pay much more attention during a crisis because it makes very visible the role of public health. And as I said, when you prevent things from happening, and preparedness gets less attention and can sometimes be forgotten over time. But I do think that the fundamental principle in the end is about building resilience in our population. And that in order to do that, it's not just about public health, it's about other sectors. Building community resilience is about communities and their leadership being empowered in different ways to do that. So I do think that it's not just a public health investment, but if we can make the case, I always say I like to help other people spend their money. And that's because, you know, if I can advocate for other departments to use their resources to help build community resilience, to reduce inequities, that will absolutely put us in a better position for the next pandemic. So I think we have to tackle the sort of investment issue in different ways. And now the economic case is just so evident that that clearly isn't enough to say, an ounce of prevention, and the fact that $1 spent in public health can probably save you at least, I think it's something like $14 in healthcare. But I do think as society as a whole, we need to think about prevention more. We build it into our daily lives and daily habits. So a lot of what public health do is to do that. And maybe it is to have a more innovative approach in all sorts of ways, leveraging behavioral insights and social science to get our population healthier in between pandemics. In terms of pandemic preparedness, we do have to think bigger. So this is sort of partly my message, is that it cannot be public health and the health sector planning and then hoping other people will listen and know that they play a role. It has to be systematically built into the plans, the linkages, the standard operation procedures, the checklists, so that as things escalate, everyone will know what the role is, and that we move into gear really, really fast. I do have to say that I was quite heartened, as the news was announced about the restriction of international borders, that at the same time there was an announcement to support people in being able to observe public health measures. That needs to be solidified so that it's really obvious that's what you need to support public health measures. So I think that there are many others that I have to engage to say, well, how do we make the most effective case for public health going forwards, and using the lessons learned from this pandemic.
Thank you, Grant. Follow-up?
One quick follow-up. Thank you for that answer. You mentioned empowering functions of government. We've heard a lot through this pandemic about perhaps more obscure sections of the public health agency that, I think most Canadians and most parts of governments wouldn't have been thinking about a few years ago. The emergency stockpile, for example, or GFIN. How do you think those can be empowered so that they run smoothly, in between crises?
Yes. So again, I do think COVID-19 has, catalyzed those discussions, if you like. So GFIN is something that we should be proud of. We need to think about what the next iteration of GFIN looks like. Internationally, we'll be sort of linking it with other health intelligence systems. There is a relook at the GFIN itself to see how we can strengthen that. But it does sort of give a very real-life example, in fact, of Canadian technology, algorithms, expertise in this area that nobody's ever heard about. But if you asked international partners, the World Health Organization, they'll say, look, that was the forerunner of, health intelligence, and that we need to now think of what it would be like. How much investment do we need to look at the next iteration? So absolutely, we do see it as a opportunity. There will be a fundamental look at the National Emergency Strategic Stockpile and its role. We had to accelerate and stand up really, really fast, and during this pandemic, we've seen also linkages to other government departments, PSPC and others, who put in contracts, who can sort of help our industries retool. So looking forward, we got to reflect back on the lessons learned and go, well, how much do you need in between pandemics, and then what way do we scale up? That's flexible, scalable platform, I think, operationally is what we need. And so, I do think, as I say, going forwards for the Public Health Agency itself, we need to continue to remember this moment in history and why we need those capacities.
Thank you, Doctor. Operator, next question.
There are no further questions registered at this time. Une autre question pour le moment.
Merci beaucoup. C'est ce qui m'a fait notre conférence de presse pour aujourd'hui. That will be all for today's press conference. Thank you.
Thank you. Merci. The conference has now ended. Please disconnect your lines at this